So for people joining us now, or who you've been with us for a bit, the next two talks are essentially broad wins. And so you see Priya's slide up there, celebrating wins, what we've been able to accomplish. And after that, we'll have Kurt Langlot. So without further ado, let's start with Priya's presentation.
Just want to make sure I'm not on mute.
Yeah, we're seeing your whole browser. I don't know whether that is intentional or not.
No, that's not intentional. Okay. Yes. Oh, you meaning, wait, you can see the top two? Is that what?
Correct.
Yeah, with Google Slides, I don't seem to be able to do anything else. So that's fine. Unfortunately, that's how it's going to be. But okay, so without much further ado, hello and welcome to the inaugural Starr Informatics Summit. For those of you who join later, I am Priya Desai, and I'm the Biomedical Informatics R&D lead of the Research IT team and the product manager and product owner for Starr. This is our first ever Starr Informatics Summit, and something, as we said before, we're really hoping will become an annual event. So thank you for being here to celebrate the vision, the accomplishments, and our journey so far. So a little bit of context. Stanford School of Medicine's mission statement is to educate and inspire leaders in medicine and science who will improve human health through discovery, innovation, education, and the delivery of outstanding patient-centered care. To get there, we need outstanding leaders, scientists, and doctors, which we have, as well as data, good quality, reliable data. And that is where Starr comes in. In today's digital era, with AI and ML becoming more mainstream, multimodal data-driven approaches have sort of really emerged as an important driving force for smart healthcare systems, with applications ranging from disease analysis to triage, diagnosis, treatment, and better patient care. In 2016, the vision for a new significantly expanded data lake, STAR, which stands for Stanford Medicine Research Data Repository, was born, with the goal to host multiple linked analytical data warehouses containing a range of different data types, all in one place. So a STAR was born. Historically, a lot of this data has existed in silos. Our goal is to break down these silos and aggregate it for research. The vision for STAR is to create a single integrated data lake containing clinical data of different modalities, to bring clinical data from its raw state to an analysis-ready state, and eventually to make much of this data self-service. So STAR will contain structured and unstructured, raw and analysis-ready data. So how far have we gotten? On the left, I have listed the data types that are currently in STAR, and on the right are the services that STAR supports. STAR contains the raw EHR data from Clarity as well as HL7 feeds from both the adult as well as the Stanford Children's Hospital. It supports two data models for EHR data. We continue to support the STRIDE data model, which may be familiar to many of you. It has supported the Stanford community since its launch in 2008. It's a homegrown data model, and recently we also started supporting the OMOP common data model, which George has talked about, and I will say more about that in a bit. STAR contains radiology images from both hospitals. This includes MRIs, X-rays, ultrasounds, CT scans, etc. It also contains the bedside monitoring data from the Children's Hospital. The last box on the bottom left is for all the ancillary data types that we are still in the process of bringing in. So as Michael mentioned, the vision for STAR was first conceptualized about 5 years ago, so in 2016, but it was 2018 before the pieces really started falling into place. Our team worked on a radiology data vending pipeline that would take in a user's request, extract and de-identify the images based on their IRB, and deliver the data securely to the user in a matter of days. So far, we have delivered about 450 terabytes of imaging data since this pipeline was launched. In 2018, NERO, which is Stanford's secure HIPAA-compliant big data computing platform, went live. In 2019, we converted the EHR data from both our hospitals and affiliated clinics to the OMOP common data model. OMOP allows users to generate evidence from a wide variety of sources, as George explained, in a standard data format. So it really allows for multi-institutional collaborative research across the world and is supported by an active online global community. Our OMOP data is refreshed and updated weekly. All Stanford researchers, and I repeat, all Stanford researchers can access the de-identified OMOP data pre-IRB. Our OMOP data set includes de-identified clinical notes, and these are available, again, to all Stanford researchers. The researchers can access our OMOP data via the NERO platform. We created a series of 4 one-day tutorials to help familiarize our researchers with the OMOP data, the NERO computing environment, and all the other tools available at Stanford. Since the start of the pandemic, a lot of these tutorials have been made available on our Starr YouTube channel as well. And so far, we've graduated about 65 researchers. To make analysis using the OMOP data easier, we expanded our toolkit to include Atlas. Atlas, as George mentioned, is the web-based tool developed by the Odyssey community. With Atlas, researchers can create patient cohorts, define phenotypes, and run characterization studies. Our Atlas, so each institution has their own instantiation of Atlas. So the Stanford Atlas supports both the Starr OMOP data as well as Optum claims data. In 2021, we've been focused on trying to expand out our Starr suite. We've expanded the OMOP data model to include de-identified zip code data. And this is particularly exciting because it will allow us to link to publicly available social determinants of health data sets, which are maintained by our business partners at Google. I know there was a chat question about health equity research earlier. So, I hope this refers to that. Stanford recently joined the PedsNet consortium, and we now have data from the Children's Hospital in the PedsNet data format as well. Additionally, we've brought in identified and de-identified bedside monitoring data and metadata from the Children's Hospital. I really want to take this forum to highlight some of the innovations done by our team at Stanford as we built out this data lake. Our initial priority was really to leverage cloud technologies to get Stanford's EHR data into the OMOP data format. We were among the first institutions to successfully get our OMOP pipeline to run entirely on the cloud and our data on BigQuery. So this basically means our OMOP queries run 10 to 100 times faster than typical SQL queries, allowing you to really conduct observational health analysis at scale. We developed a text de-identification pipeline that we call TIDE to mask PHI in unstructured text. So in addition to just the standard safe harbor practices, TIDE implements hiding in plain sight algorithms, which basically make it impossible to distinguish between real and surrogate PHI. This pipeline can process about 130 million notes in less than 5 hours and costs us about $550 to run. We have also mapped some of the most commonly used flowsheet data fields, including critical ICU variables such as central venous pressure, the Glasgow Coma score. And this has been particularly helpful for COVID studies. As mentioned before, we developed a radiology pipeline to reliably and efficiently de-identify DICOM imaging data and metadata. It was really challenging to do this because it turns out that the position of the PHI information in the radiology images is not standardized. So it was quite a feat actually to accomplish this pipeline. Our pipeline is quite fast and cost effective. So for example, it can identify about 100,000 x-rays in less than an hour and costs about $7.95. Finally, we have brought bedside monitoring data into Starr. And as we've done that, we've converted it into the open source PhysioNet format from the proprietary Philips format. To improve the usability of this data for research, we also used ancillary EHR data like the admit-discharge tables to link the bedside data to MRNs. And with this approach, we've really been able to assign MRNs with like a 75% coverage, 95% accuracy. This has been a challenging year, but Starr team has got a lot accomplished. So kudos to you guys. The Starr data has been part of many national COVID-19 studies and has been used in over 12 publications. With our data in the OMOP CDM, we've been able to participate in about 25 Odyssey network studies. The Starr OMOP data powers the Green Button project, which is a consultation service where clinicians can ask for a specific clinical question and receive EHR data on demand from similarly presenting patients to aid decision-making. Starr has provided imaging data for over 90 studies and their respective publications. Our goal here is really to enable our users to leverage the data in Starr and answer their research questions. And we want to support them in whichever way we can. So to that end, we have a Slack channel for our Starr community. We offer weekly office hours. We have done our best to keep our documentation up to date. And then last year, we launched a YouTube channel where you can access tutorials and past talks. So for some people who had asked in the chat, this summit is also being recorded and all the sessions will be posted, all the slides will be made public. Our long-term vision for Starr is to integrate clinical data of all modalities into a single data lake, and make the data self-service. But in the short term, here's what we have planned. We are rolling out a self-service product that we're calling custom datasets. It will allow researchers to generate a custom data set from a pre-generated cohort and de-identify it based on their specific IRB requirements. We are also in the process of integrating all our radiology imaging data. So this includes ultrasounds, CT scans, MRIs, all into a single data lake, and at the same time extract the metadata. So our goal is really to link this imaging metadata to Starr OMOP. And we hope to do it both in the link it to the identified OMOP, as well as have the de-identified metadata, which will be linked to the de-identified OMOP. And we hope to make this also available pre-IRB. We are working with the Odyssey Oncology Group to bring oncology data into Starr OMOP. And we are also planning to deploy ACE, which is the advanced cohort engine, which was developed here actually in Shaw Lab at Stanford. ACE allows for rapid electronic phenotyping, cohort extraction, and exploratory data analysis. It will use Starr OMOP data. We are also planning to bring in the insurance plan type and payer data and bring it in at the encounter level into Starr OMOP. This is a request we've heard from many of our users, and it's something that we're actively trying to do. We hope this payer plan data, type, insurance plan type, and payer data, along with the zip code data, will really enable more health equity research. So again, as mentioned before, our goal is really to enable our researchers, and to that end, we do try and have surveys frequently. In a recent survey, our community indicated that they really want to learn more about network studies and how to leverage Starr's multimodal linked data. They said they wanted to see more Python libraries and modules to explore and analyze the Starr OMOP data on BigQuery. And we've taken all of that feedback into account, and we have plans underway, so stay tuned. Here are some links to just some of the STAR resources, including the STAR support services. You will meet many of those, many of the STAR support service folks this afternoon in the breakout rooms. And this is my last slide. I really wanted to end with a big shout out to our leadership, our business partners and collaborators, and of course, to our amazing technology and digital solutions team, without whom none of this would have been possible. So thank you for your support, your hard work, and I look forward to continuing the STAR journey with you. I really believe the best is yet to come. Thank you.
Thank you, Priya. We're starting to see a couple of questions, and it's an amazing success story. The 11 people in the TDS team have practically accomplished most things that Priya talked about, with some help from, I'll give a shout out to our Odysseus business partner. I see two questions. They're real quick. Can we differentiate OMOP data based on its source, SHC or LPCH?
Yes.
All right, and then for how to do that, we'll probably point to documentation or a YouTube video.
Documentation, YouTube videos, I'll make sure to add it to the FAQs.
And one more, to what degree does STAR accommodate differences in data variables commonly needed for different types of care units? So clinic-based, ICU, emergency department, operating room. Like how cleanly can we figure out the venue or site of care?
I will admit that it can be muddy. It depends on how much information we have in the raw data that we're getting in, because it really just depends on the raw data. I will say that some of this information can be made clearer. We are working to do the best that we can, but some of it will be, to some extent, it will remain muddy, because if the information is not in clarity, then there's no way for us to know.
Yeah. So to the person asking the question, this is a can of worms. Not easy would be sort of the fair and honest answer. It is possible in 30% of the situations reliably, I would say. One more question. Are STAR resources available for small unfunded Stanford research projects?
Could you repeat that? Are STAR
resources available for small unfunded Stanford research projects?
So the only caveat here is that to access STAR resources, or to access STAR data, you need to be part of Nero, and you need to have a Nero GCP, a Google Cloud Platform project. In order to get Nero GCP project, you need a credit card or you need a PTA number. We have a lot of people who are using STAR resources and have GCP projects. There are really ways that it's not particularly expensive to use the STAR resources. The resources otherwise are free. We host the data for you for free, but you would need to have your own Nero GCP project because you would pay for the queries. But the queries really are not that expensive. I mean, it costs $5 for 1 terabyte worth of data queried. So, from all the people that we've worked with, it really is not particularly expensive. So it's not 100% free, but our time and our resources, our help desk, our office hours, all of that is free.
All right. So in the interest of time, I'm going to start. Keep us moving, keep ahead. The short answer is that it's practically free. The queries, I mean, it's like $5 for a terabyte of big query. I mean, it's going to last you years, depending on what you're doing for the queries. So it's practically free from that standpoint. So with that, I would want to invite Kurt Langlois, who's going to talk to us about
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.